Now I am also have you guys on mute so that we don't get any interruption, and then I can go ahead and unmute you guys a little bit later if we have some questions right toward the end. So let's go ahead and get started. This is Lynn Schrader, of course, and this conference call this morning, this webinar, is really intended to give a basic overview of PPACA. And the intent here is that if you hear this enough and you'll become the go-to person for health reform issues in your community, you may be able to deliver this presentation yourself and or at least have the talking points down so you can talk to people and become that, as I said, that go-to person or that expert in the community. So let's get going here. So we start out with the problem of uninsured Americans and rising cost of health care, in particular the premiums that I'm referring to here. Now remember, you guys, as I deliver this presentation to you today, you may know some of this, but I'm giving you the talking points so that you can deliver this message to your clients, other business associates in your community and in your marketplace. So the goal would be that you could deliver this. If you'd like my help, and I'll throw it out there again, let me know that I will come down into your communities. We'll deliver this message together with the whole point of being able to tie you to health reform in your community so that people know you're the go-to person in your area. And I think that's what we're doing right now. I've had a lot of people say, I'm just not going to deal with this. There's a lot of questions. It keeps changing. And my response back to that is, healthcare reform is here, and I had to get myself out of the denial mode. So let's get yourselves out of the denial mode. We are moving forward with healthcare reform in Iowa, and I'm going to give you guys the presentation that you need today to be able to deliver to the marketplace. So I know some of you might be using this twofold. You're still learning, and that's okay. So know that I'm delivering this to you to learn, but also as a way for you to be able to deliver this message to the marketplace. And show that you're the go-to person in healthcare. The other thing that could happen at the end of this meeting and at the end of training this summer is you decide you're getting out. And that, we believe, will happen in our marketplace. There'll be agents that say, I'm not going to do this. This is too much more to learn, or maybe you're right at the edge of thinking about retiring anyway, or maybe you've got a core business of financial products and property and casualty, and/or property and casualty, and you just said, you know what, forget the health. I'm going to focus on my other core business. Then I would just encourage you, find a partner. If you need help finding a partner, somebody that you can refer your leads to and work out some kind of a split in commission, someone you can trust, talk with us about that, because we're helping to set up those arrangements all across the state of Iowa for those that are saying, I'm out. So this is intended to, you're either in or you're out. So start thinking about that, because as you continue to get emails from KHI about what's going on with healthcare, and then the mandatory training that'll be coming this summer. If you want to play in the under 65 and small group space, you must attend training. And so you'll be thinking about whether or not you want to recommit yourself to the health insurance market or not. Okay, so knowing that we've got this problem, and also knowing that we've got some interesting things happening in the demographics in our population here, as well as, I think, a lack of marketplace competition. So these were some of the things that were factored into how PPACA came to be. And as you guys know, we're calling it PPACA, ACA, Obamacare. Those are all terms used interchangeably. And we all know now as well that the president has embraced Obamacare. So we can talk about that with no disrespect intended. So, okay, so as we move forward here, here's what's really incredible. And just learning some of these little tidbits so that you become that go-to person in your area. To know that when I downloaded, I went out and I literally Googled PPACA. And up came the link to a 906-page PDF document. And so I read the law. You remember it talked about, well, it was 2,400 pages was in the bill. Well, when the bill became law and was now down into a PDF document, it's about 906 pages. So I have that if anybody would like it, or you can go online and Google it. I went through that to build this presentation. And so I found that the way they wrote the bill that now became law was clustered in several areas. And so I'm going to start with the first one is called Improving Coverage for Individuals and Groups. And this is how the law then became to be and how it was written to say the first section we need to tackle is improving coverage for individuals. So what I want to highlight here is the second to the last bullet. I probably should have put this at the top because it's probably one of the most important things about the law, and that is insurance for the uninsured people with pre-existing conditions. This is guaranteed issue insurance now. So if you don't remember anything about health reform, we know now that it is offering guaranteed issue insurance for anyone and everyone. We know that this happened for children sooner. This already started for kids back a couple years ago. And another note to just know, this was signed into law on March 23rd of 2010. You guys, here we are over 3 years later. And, you know, I always chuckle too when I give my presentation. And these are some of the things you guys can chime in with. But I remember, and you guys remember because you're close to healthcare, this happened, and I think I was in disbelief. I remember the night I watched the Senate vote, and as I just sunk. It happened in the evening. I remember I was at home and watching it, and this thing got passed. So then, we don't know that this is ever really going to stay. So remember then there was a lot of downtime. Some things came into being, but nothing too critical. The kids could get on, the lifetime and annual limits, the rescissions, all this stuff started to come in, preventive coverage. These are all positive things, and this was fine. But then if you recall, the closer we got to things really starting to heat up, all of a sudden there was a lawsuit filed to see if this was constitutional. So then we all waited to do it, you know, hey, maybe we shouldn't do anything, and we'll wait and see if the Supreme Court is going to throw this thing out. Well, lo and behold, they didn't. Well, then what was the next thing we were waiting for? Well, then we were waiting for the presidential election. Oh, there was all this talk about repealing of Obamacare, and we waited. And lo and behold, the administration was retained. And so we thought, now, I mean, what's going to happen now? And you'd maybe hear some of our representatives talk about repeal and still trying to do something. Well, gang, I got to tell you, we've got to put our heads down and we've got to go ahead with what we know today. And that's what we're going to talk about. And that's the message you bring to the people in the community because they listen to the news. And when the news is telling you, oh, this isn't looking good, or oh, some senator gets on and starts going on about Obamacare, the reality is, you guys, states are moving forward with this. Now, fast forward to Governor Branstad having to make a decision then in December about what was going to happen. So it was after the election, and Governor Branstad had to decide what to do. And we'll talk a little bit more about that in the healthcare section or the exchange section here just in a little bit. But it is moving forward. So I was just in a meeting, a NAFA meeting yesterday, and our new commissioner, Nick Gerhardt, spoke, and things are moving along. We are on track in Iowa. So my point is, some things are already happening. Some things are going to happen effective January 1 of 2014, and we are right on the cusp here, gang. So we've got to move forward with what we know, and we know a lot. So the Part D, I throw that on there for a lot of us that also play in the senior space. Just know that they're working to close the donut hole. This portion of the law says the donut hole will be closed by 2020. Now, I was in another session with Jess Patton, who delivered a phenomenal piece. He always does such a great job. A couple hours I was over in Cedar Rapids on Tuesday, and Jess did another presentation on updates. He has seen, and I have not seen yet, the president's budget for fiscal year 2014, and in there he proposes closing the donut hole actually by 2015. So it's interesting. Well, more to come on that, but just know that at least it's in here and scheduled to be closed by the year 2020. So the next section that they talk about in the law, now we're probably on page of that 906-page PDF document, we're probably on page 250 right about now, is now this section is called Health Insurance Market Reforms. So this is what's mandating insurance companies what they have to do. So not only did they on the prior slide have to now guaranteed issue take everybody, that impacted them as well, but that was such a positive impact for the marketplace. If you can think about this, right, think of your market and think of, have you ever heard anybody say, if I could only get my own health insurance, I would quit this job? And they might only be 55 or 60 or 62 years old. But something that could have dynamics in our marketplace was based on that, and that was that guaranteed issue. Now we're talking about things, as I said, on health insurance market reforms that are going to really impact also the consumer, but greatly impact the insurance company. So just being comfortable with these is important. So knowing that we already talked about being able to put kids guaranteed issue policies without any pre-existing conditions. Now, they still could be rated appropriately or excessively, but they couldn't be denied coverage. Now, this is a big one, this next one on prohibiting excessive waiting periods. This one does go into effect on January 1st of 2014, and we've gotten more guidance, and the guidance says the maximum waiting period, new hire waiting period that any employer group can put on their employees is 90 days from date of hire. Well, now when you peel that back and think about this, if you said 90 days from date of hire, you can't just say a 90-day new hire or a new hire waiting period, because a lot of times people are hired on odd days in the month. You can't assume that everyone will get hired on the first of the month. So the law says 90 days from date of hire. Translate that into group speak, and this is another little tidbit that you want to make sure you're having conversations with any small business customers or prospects or associations that you have with small businesses. Bring them that little tidbit to say, hey, what's your new hire waiting period on your group? Do you offer benefits? These are all great questions to be asking business owners, or making sure that they know. If you already have a block of business, send out a note that says, remember that you must modify your new hire waiting periods to, cannot exceed 90 days from date of hire. So what the language really needs to say is that the benefits will start 60 days following the first of the month following hire, right? So that way they will maintain, they'll stay inside of the law by saying 60 days from the first of the month following their date of hire. Okay, so that's just a nice little tidbit, and that's a good way for you to get out there and be able to explain that to small business owners. So the last two bullets are all around the minimum loss ratios and the rating methodology, and this is so huge because this is what impacts rates, and it also impacts competition in our marketplace. So let's start with the minimum loss ratios. Now, some of this, I know you've been hearing things probably on the radio and the newspaper, but let's make sure we're all clear that insurance companies, if they play in the individual or small group space, they can only garner a 20% margin. So another way to say that is for every dollar they collect in premium, they must pay out 80 cents in claims cost. So there was a big to-do around are agent commissions inside of that calculation or not? Now, we fought hard. I'm honored to serve on a coalition representing the Big I, NAIFA, and NAHU, and we had a voice. And if you're a member of any of those, I encourage you, if you're not, become a member of one of those three organizations. But we gave voice to this concern that we had. We took it to our commissioner. Commissioner took it to the National Association of Insurance Commissioners, and they were overruled by Department of Health and Human Services that said no, broker commissions will stay inside of this calculation. So that did drive we believe it drove some insurance companies out of our market, which is the wrong thing to do right now for the client. We need more competition that can drive down costs. So recently in Congress, there has been some momentum. It's not to the place where it can be discussed in session yet, but there's something called the broker bill that's being introduced so that broker commissions are not factored into the minimum loss ratio calculations. We believe that'll help make sure that our commission doesn't continue to erode as it has, and all of us took a big cut in the 2010-2011 time frame. So anyway, just know that we're following that. We'll keep you posted on that. Now, look at how it even gets tougher if that insurance company plays in the large group market. They can only garner 15 cents a margin, meaning for every dollar they collect, they need to pay out 85 cents in claims costs. So this is really putting the squeeze on insurance companies. But here's the next one that really does it, and this is rate impacting definitely for the clients that we represent. Today it's a 5-to-1 rating methodology, meaning any insurance company that offers a product, if they charge an 18-year-old $100, they can't charge a 64-year-old any more than $500. So that's the 1-to-5 ratio. This just got squeezed down to 3-to-1 in the law. So it says if you charge that 18-year-old $100, the most you could charge that 64-year-old is $300. Well, that's ludicrous, right? Insurance companies are going, it costs me more to maintain some of those higher aged people. I'm going to need to charge them more money. So guess what? The lower age people are going to pay more because of this 3-to-1 ratio. So some of you have heard this, but I just want to make sure you're comfortable being able to explain that in layman's terms to the public so they understand why rates are going where they're going to go, where they're going to go. Now, I will also tell you that there's been some traction with our representatives, namely probably brought on by the lobbyists and or a lot of the insurance companies as well as our organizations. The 3-to-1 rating methodology is really going to make it tough for the young, what we call those young invincibles, right, that really need to get into the pool to help us offset because they're typically healthier. We need those people in. We need those numbers of people. So there's been some traction now trying to get that 3-to-1 rating methodology changed back to 5-to-1. At least that's what it is in the state of Iowa today, is 5-to-1. But January 1 of 2014, it's going to 3-to-1 unless they can get some other legislation passed to modify that. So again, we'll keep you posted as we see things get challenged and new rulings brought to the market. So not only the 3-to-1 rating methodology, but let's be clear on this. Age, tobacco usage, and address are the only 3 things that can be used to rate premiums, right, to help develop what the premiums will be to provide rates to the, I'll call it the 1 to 50 marketplace. So 1 meaning single policies, or 1 to 50 meaning an employer group policy. So think about this. In the 1 to 50 market space, it's guaranteed issue. We just talked about that. But now we know that they can only be rated on how old are they. So we'll need to get date of birth. Do you use tobacco? And where do you live? Notice there's no gender in there. So it's gender neutral. And then I have to laugh because in Jess's class on Tuesday, he talked about tobacco usage. There will be a question on the application. Do you use tobacco more than 4 times a week? And I don't know who came up with this, and we were kind of chuckling about it, and maybe this will be modified, but right now the application is asking. And if somebody says no, and maybe they really smoke 5 times a week, or maybe they only smoke 2 times a week, but they answer no, I don't use tobacco any more, and it's used tobacco any more than 4 times a week, yes or no. What we found is, and what we know now, unless something changes, there's no way to go back on that. And there's no way to go, well, you do use tobacco. Well, no, I don't use it anymore. So you're just diagnosed with lung cancer right after you got your policy. Well, how do you go back and challenge somebody's usage? And so we find this very interesting that they've chosen, it's a question on the application with really no way to go back and verify. Because, let me also mention this, in the law it says if somebody uses tobacco, the insurance, and they say yes on their form, I use tobacco more than 4 times a week, then their rate can be 1.5 times the regular rate. So if somebody's going to pay $200 for a policy, it's okay to charge a tobacco user for that same policy $300, 50% more, right, at 150% rate. So it's amazing. Again, some of this, the law is age, tobacco usage, and address. The interesting parts are how is this going to be administered? How is this data captured? So what we're seeing is there could be some interesting things that happen in the marketplace based on somebody saying, no, I don't use tobacco more than 4 times a week, and they'll get the non-tobacco rate. Think about that when you and I are sitting there talking to a client, and they say, yes, they use tobacco more than 4 times a week, and we give them their rate, but their spouse sitting next to them does not. And they're the same age, and they live at the same address, and they're going to have 2 dramatically different rates, okay? So anyway, interesting point I want to share with you. So let's move on now to these health exchanges, because if there's the 2 main things that you want to remember about the law, the 2 biggies, the one, as I said, is guaranteed issue, and the second is these health exchanges. And I got to tell you, as of really within the last week or 2, they're now calling them marketplaces. So I will update this PowerPoint presentation. It will now be called a health marketplace. Now, the reason, and again, I just picked this up on Tuesday from Jess and his connections to Washington, D.C., but the health exchanges, they were trying to convert all of the law into at least 4 other languages, and one of those being Spanish. So as they tried to convert the word exchange into Spanish, they found that they did not have a good Spanish translation for the word exchange. And this I got directly from Jess, who got it directly from someone in Washington, that said the best that they could do in terms of trying to be able to translate this properly and fairly in all these other languages to change the word exchange into marketplace, so that would be understood in all the other languages that we're converting this into. So now you'll continue to see health exchanges, but now called health marketplaces. And I think it's kind of confusing because I use the word marketplace to mean generic, general marketplace, what's going on in the market and in our marketplace. So we'll just need to be really sensitive of that. We'll call these now health marketplaces is now going to be the new word for health exchanges. So as you know, we had a choice in Iowa to select a state exchange, federal exchange, or a joint partnership. Well, as I alluded to earlier, based on the Supreme Court, based on our political process and our election for presidents back in last year in November, and we realized, right, there is going to be no regime change, and this probably is not going to be repealed. Governor Branstad had a limited amount of time to decide what to do. He elected to do the joint partnership. This way we've got federal help coming in, but Iowa still gets to have some say, and we are dictating things like, and this I got directly from Nick Gerhardt, we get to be the state that actually approves the plans that want to come into our exchange. So we have some additional authority in our state because we've selected a joint partnership. So now picture this as really an electronic marketplace. The intent that we believe the government had was to streamline all products, almost standardize, if you will, and I hesitate saying that because it doesn't go as far as standardizing the plans like we have in Medicare with our supplements, but they're trying to get into that place where the consumer can have an easier job of comparing plans inside of these marketplaces. Today it is very different. We have all kinds of applications. Think about that. When we try to get an application completed for somebody, there's multiple carriers, multiple applications, multiple processes to try to get through underwriting. All that goes away, and we're going to learn all about how this is going to work this summer in the mandatory training that we're going to be having if you're going to play in this space. So you're going to learn how do we go to this electronic place, and I'll be able to compare all the carriers that have selected to be in this marketplace. I'll be able to compare them side by side. Hey, not a bad deal, right? There's one application that the customer will complete. So it makes our job a little bit easier, and the job, of course, for the client to be able to get a quick response back. You will be able to get them a rate right then, right there. It's guaranteed issue. So throw out that idea that I'm waiting for attending physician statements, or they're trying to figure out if they should complete another whole application with another carrier and see how they'll treat them. That's all gone now. So in this marketplace, or this place that we can shop, that you will be able to help your client shop, will be qualified health plans. They call them QHPs. These QHPs inside of the exchange must put essential benefits inside of all their plans. Now, I want you guys to know this, that essential benefits, and there are 10 of them, these essential benefits are mandated for any plan in the 1 to 50 space. So this is not just a health exchange thing. So let's say this, or a health marketplace. Let's say this, that when Blue Cross offers plans, like today they have their the value plans, their enhanced, and their comprehensive plans. Those plans will all move into a metallic plan with essential benefits, whether or not Blue Cross plays in the health exchange marketplace or not. Okay? So these guidelines of essential benefits and this standardization, if you will, of the plans, the metallic plans are the bronze, the silver, the gold, and the platinum. These metallic plans have what they call actuarial values assigned to them. So unlike our Medicare supplement plans that are standardized, or all the benefits are identical, that's not true with these plans. These plans have an actuarial value. So there's a little more what I call wiggle room for the insurance carrier to be able to say, well, okay, if this is a bronze plan, it must meet a 60% actuarial value. What does that mean in layman's terms? It means that in general, the expense to the consumer in general cannot exceed 40%, where the insurance company would pick up the other 60. So the plan must cover about 60% of the costs, the medical costs that a consumer would be burdened with, okay? So a 60-40 plan. So what does that really mean? Well, I've talked to some of the carriers that are working with these formulas and these calculators, right? And they've said, you know what? There are many variables in a health insurance plan. We all know that, right? We know it's deductible. We know it's the pharmacy plan. We know it has to do with co-pays. We know it has to do with, do we have first dollar coverage or not? We also know the out-of-pocket max plays a major role. So we've got, yes, co-pays, co-insurance, deductibles, and out-of-pocket maxes in pharmacy plans, but the two that they called move the needle will make it go from a bronze 60% actuarial plan to a silver 70% actuarial plan is really the deductible and the out-of-pocket max. Now also know that there are limitations on the out-of-pocket maximums for all plans, again, in this space. And the out-of-pocket maximums mirror the HSA, or those qualified high deductible health plan out-of-pocket maximums. So very interesting. We run, and I'll just use some round numbers, around $6,200 for a single and around $12,000 for a family. So know that those out-of-pocket maxes, there's some caps on those, okay? So the carriers are saying that's deductible level, and the out-of-pocket max is what makes it jump considerably from a bronze to a silver, from a silver to a gold. Now the gold is an 80% actuarial value plan, and then of course the platinum being the top, being a 90% actuarial plan. So when you hear about these metallic plans, you just know it's bronze, silver, gold, and platinum, and they have an actuarial value calculator. In fact, I haven't been out there, but on the Kaiser site, I believe they have a way that you can even play with a plan today. You could take a plan that you might own yourself and plug in some variables and come out with maybe something close to what your plan would be equivalent to. So here's what we understand going to be happening with all of the individual carriers that I'll say are non-grandfathered. Remember, there are some grandfathered plans. I remember this quote. Do you remember this quote where President Obama said, where President Obama said, if you like your plan, you can keep it. Well, for those that haven't changed their plans, they stayed grandfathered. They haven't changed them since this was signed into law on March 23rd of 2010. So you've got some people in some old pools that are probably considered grandfathered, okay? Now, those people will probably want to move, but they won't have to move. But if anybody bought one of the individual plans, especially if Blue Cross came with a new product, which all of the HMO plans are new, those are all non-grandfathered. Those will be automatically moved into a metallic plan come January 1 of 2014. So they're going to be doing the calculation on those current plans they have and determining where those slide in. So consumers now, if you can imagine this, and bless us all, it happens at the same time we've got Medicare Part D going on, but open enrollment for people to move plans, especially for those that don't have insurance today. That's kind of the big deal for the open enrollment. But if you've got insurance today and you want to be able to move into a plan, or you don't have insurance, you want to be able to buy a plan, you'll be able to do that from October 1st to March 31st for January 1, February 1, March 1, or April 1 effective dates. So there's the open enrollment period to make these changes, right? So very interesting, though, with the metallic plans and what's going to happen with some products that are going to be moving in. So remember, too, that there will be off-exchange products, okay, that are still, and that's what Wellmark, if they play in the exchange or they don't, they'll be moving all these clients into these off-exchange products, okay? So these products must also meet the metallic and the essential benefits. So the reason somebody might look, say, so you've got one option here to be off exchange. They might already have their policy there today or will be there today, effective January 1. Then the reason that somebody might want to play inside of this exchange or this marketplace is because of the subsidies that they'll be able to get. Okay? Now, let's just also clarify that if a company, and there's a new company in town, you've heard about that, and KHI was awarded the contract, the wholesale contract, to sell for Co-Opportunity Health. So we're very excited about this. Only one of 3 wholesalers were selected in the state of Iowa to be able to market Co-Opportunity Health, and KHI is one of them. So Co-Opportunity Health, because they are a co-op and because this is part of Obamacare and they've gotten money from the federal government to start this new insurance company, they must be in the exchange. They've already told us they will also operate outside the exchange or outside the marketplace. They also have large group products or products over 50. It's still considered small group, but anything outside of, remember, the exchange is only 1 to 50, okay? So anyway, Co-Opportunity Health will be inside and outside the exchange. The point is if they offer the plans inside and out, the rates must be the same. So you can't give anybody a rate benefit. They can't by being in or outside the exchange. And I want you guys also to know, make sure you know this, that you are compensated both inside and outside the exchange, and the compensation must be the same. So they can't pay us one thing if we help somebody inside the exchange and something else outside. So that's all good to know. Okay. So the subsidies then will be based on income. Now, I have a slide, and I shared this at one of our update type meetings of the subsidies. And in fact, I've got it, and Brenda's also got another presentation she's been delivering, and it's got all the updated numbers. But it's crazy to think, for a family of 4 that makes up to $90,000 a year, they will be eligible for a subsidy inside the exchange. 400% of poverty is what these subsidies are based on. So that's why you want to look at your folks and say, look, as a single person making less than $45,000 a year will probably be eligible for a subsidy if they buy through the exchange or through this new marketplace. So as agents, we're going to be sitting down with folks, and this is impacting everybody, you guys. Think of that spouse that's on a group plan with their spouse who's the employee. So the spouse that's not the employee of a group plan, maybe they're an independent contractor, they're in business for themselves, they do part-time work, they're a stay-at-home parent. Those folks, if they make less than $45,000 a year as a single, and if they're not offered group coverage, will be able to go into the exchange. So you're going to need to sit down and say, okay, what will it be if you go to the group, if you're even offered group coverage? What would it be inside the exchange? Oh, and by the way, if they are offered coverage on that group, they can't get a subsidy inside the exchange. So, okay, but I'm going to really have 3 options to look at. Let me look at what will it be if I'm on my spouse's plan, or if I'm the employee and I take my group employer plan. What would it be if I went to the exchange based on my income? And what would it be if I went outside the exchange? 3 places to look for rates. And my slogan, and I shared this with Brenda and Andy, is do the math. Everybody's going to be doing the math. So everybody is potentially a prospect for you. And you'll be compensated inside the exchange or outside the exchange. Now, Wellmark hasn't put this in writing yet, but they've said their commissions will remain the same in 2014. So we at least can count on that. We will be compensated. You will be compensated whether you write a small group plan inside or outside the exchange, whether you write an individual plan inside or outside the exchange. You will be compensated, and the compensation they are not changing their compensation structure for 2014. Now, we hope this will drive increased competition. So I'm sharing a lot with you guys. My talking points to you on using this slide are a lot different than when I deliver this or when you might deliver this to your clients or some prospects or small groups, etc. So just know that the points don't change, but what I speak of and what I highlight in this will change based on who I'm speaking to. So we are excited about increased competition, Co-Opportunity Health. By the way, if you are committed to this business and you have not let us know that you want to market Co-Opportunity Health with us, please send us an email. You can send that to me, to Brenda, to Nicole. Nicole's keeping track right now, as we will be submitting a list to Co-Opportunity of all agents that want to be appointed, and only those appointed agents will get an invitation to training. By the way, the appointment fee is $40. So are you willing to make a $40 commitment? Now, think about that too, because the $40, as we do with all of our appointment fees, and this is how we look at it, that's your skin in the game. Are you willing? Wellmark's is $10. Why is Co-Opportunity going to be $40? because Co-Opportunity is also going to do a background check on everybody, and I don't believe Wellmark does that today. If they do, they don't charge us for it. And those fees, as you know, we go ahead and we pass those on to our agents. And so if there's a concern or an issue that you have with that, then maybe that's a way for you to go, I don't know how committed I am to this marketplace. Because not everybody will be getting a contract with Co-Opportunity Health. We're not saying let's get the masses and get everybody contracted, just so you know. This is really going to be one of those things where we really believe, and my saying is boys will become men and girls will become women this summer. You either in or you're out of health insurance. You commit to it or you don't. We've got a lot of people that dip toes in the market, and our belief is that the toe dippers will move on to something else. Find the toe dippers in your area to partner with. If you're a toe dipper, find somebody to partner with. Do some referrals. KHI is happy to facilitate splits for you guys, okay? If you found a partner to do your health insurance for and you can focus on your core business and work a split, we'll be happy to do that. Okay, so the next section now, I do love the way they set this up because when I share this with you and or we share this together with your clients, they get it. And the feedback I've been getting from clients when they walk out of those joint seminars I do with my agents, with you guys, is thank you. I now get it. I know what to expect because the next meeting is going to be with you, the agent, to figure out once we get rates, and that won't happen until October 1st, you're going to be communicating with them about what next steps are. Okay, so the next section of this law is called shared responsibility, and this is the individual mandate. This is saying every American, legal, documented American, will buy health insurance or they'll face a penalty. Now, there are some exceptions. There are some religious exceptions. There are, I know, some Indian tribal exceptions. So if you're in an area where you're near a reservation, just know that there are exceptions made. And if you need more detail on that, we can certainly get that for you. Okay, so majority of people, though, will be purchasing coverage. And I liken this a little bit to the Medicare Part D. It really isn't a mandate on Part D, but they've made it almost such because they've said there's a penalty if you don't buy it, right? If you finally do buy it, you'll get a penalty. Oh, and there's this open enrollment period. If you don't have it, you can only get it once a year. The same thing, guys, is happening here. Except that it's mandated, and if you don't buy, your penalty will be assessed through your tax return. And I've had a lot of people go, so what if I don't file a tax return? Okay, those are other issues, right? If you don't make enough money to file a tax return, that's separate, and you probably need to be on Medicaid, or you need to get signed up for this because you can get credits, and you'll get a lot of help based on your income. So I'm really talking about those that can afford it and aren't buying it because they've chosen not to because they're healthy. So this is that young invincible market we always talk about. So just know the penalty is pathetic, I think, the first couple years. It has a little more teeth in it that third year in 2016. But remember, this won't be assessed until the tax year. For example, in 2015, we'll be looking back to 2014. So if you get one of your folks in your community that's young, invincible, and says, I'm not going to buy it, I'll pay the penalty, I can hardly fault them, except that I want to say, okay, I get it. It's only $95 or 1% of your income, not to exceed $285. Okay, I get it. And oh, by the way, when you do your taxes, yeah, the IRS can't come after you for that money. If you owe a payment, you can pay what you owe minus the health insurance penalty, and that's legal, and they can't come after you for that. But if you're getting a refund, they're going to take that money right out of your refund, but that won't happen until 2015, so take your chances. And then in 2015, of course, they won't assess that until 2016. So really, in 2017, looking back at the year 2016, with the maximum of $2,085, now finally, maybe somebody's saying, well, I probably should have it. It's going to cost me $2,000 and I get nothing. I pay a penalty. I might as well get some insurance for a couple $100 a month. It'll be close. But here's the other key, you guys, and this is, I referred to it earlier, there is an open enrollment period for those that do not buy coverage, and it will be once a year. So if you don't buy it now in the open enrollment period, you cannot just buy insurance whenever you want it. You cannot wait until you get sick. That was the ambulance chaser story we talked about and kind of chuckled about. And I said, hey, guys, let's everybody set up a kiosk at every entrance to urgent care and hospital, right? Yeah, why not do that? Well, We could certainly do that, I would think, during open enrollment period, kind of chuckle about that, but I don't, I haven't pursued that, I got to tell you, but during open enrollment is the time to sign people up that don't have insurance. Once that open enrollment period is closed in 2014 on March 31st, those uninsured people cannot buy insurance again until the open enrollment in the year 2014 now. Think of this, it's going to be October 1st through December 7th. Sound familiar? Yeah. Same open enrollment period in 2014 for a January 1 of 2015 effective date. So just know that they'll be locked out then if they're uninsured today. Now, I always get the question, and somebody says, but what if I have insurance but I want to change my insurance? Am I locked out? And I said, I'm not talking about those that have insurance. There will be special enrollment periods for those when you lose group coverage, when you get married, when you have a child. There will still be a list of special enrollment periods, so not to worry for those that maintain insurance. There will be reasons and times for them to be able to change. But just know this is really targeting those uninsured, those that say, I'm not buying it, okay? So those are the penalties, and this open enrollment thing, which I think is critical. I think that'll be the one that gets people in. Even if they're young and invincible, their parents are going to say, buy the insurance, right? Because you don't want to go uninsured and be in that car accident that you had no control over, or that cancer diagnosis that can come to people of young ages. So anyway, just know that. And then the next part about shared responsibility, this is where it gets into the groups. And so now we know, what does this really mean for employer groups? And a lot of people are misunderstood on this. And so let me just say this. Any group that is deemed to have 50 or more full-time equivalents must offer coverage to their full-time employees. Okay, two different terms there. So if somebody just like KHI, we have 12 employees. Okay, of our employees, I do not have to offer coverage. So even if I went through this full-time equivalent calculation, which I'm going to show you guys, I don't have to. Will I? You know what? This is where I want you guys, again, if you don't get anything else out of this meeting other than the things that says there's an guaranteed issue along with that individual mandate, right? There's a guaranteed issue, and there's these new health exchanges where people can get subsidies based on their income. It's not free, but they can get subsidies based on their level of income. Those are the two big highlights of the healthcare reform law. But this other part about groups and up to 50 or under 50, the key question you want to ask any employer is, how important is offering the health part of the benefit package you offer? Because many of them offer vacation. They might have other benefits that they pay for, a 401k plan. They might have some other ancillary benefits like disability, which is a big one. We'll be talking more in future webinars about that. How important is the health component of your benefit package in attracting and retaining top talent? You guys, this is all about turnover. If that small group, I don't care what size they are, if they don't care about their employees and or feel as though the health benefit portion of their benefit package has no bearing on turnover in their company, then they don't need to offer it. Then don't offer it. You have no penalty. It's no big deal. But we believe many small businesses might continue to still offer the coverage. Now everybody's waiting to see the rate. So see, again, it's do the math. We'll wait till October 1st so we can find out. But many of these folks are going to offer insurance regardless of whether the government says they have to or they don't have to, because it's the right thing to do to keep their business going for their talent, to maintain their top talent. Let's face it also, many small businesses have a lot of family members in it. And remember, if you offer it to your family, then you got to offer it to everybody else. So you're going to have, and let me help you if you need some help with some of your groups that are struggling with whether or not they should offer it. Not only will I come out and do these seminars with you in your marketplace, but let me help you with some one-on-one meetings if you need some help. Pull us in and let us help you. That's what we're here for. Again, if you commit to this marketplace, you'll get the support from KHI to help you move forward and to help your customers move forward, okay? So this, I'm going to skip over the calculation of full-time equivalents in just a second because I've got a couple slides on that. But before we move on, I want to share with you, if this group plan, if this employer group offers coverage, it really should meet two criteria, and that is at least offer a 60% actuarial value plan. And what is that? We just talked about it earlier. That's the bronze plan. As long as they offer at least the bronze plan, which is 60% actuarial value, and the cost of that plan to their employee does not exceed 9.5% of their income, then they are offering, if you will, a quality and affordable plan. So remember those 2 points, quality and affordability. And as long as they offer the bronze, and as long as they pay enough so that their employee doesn't have to pay any more than 9.5% of their income. Now, this is a different way to talk about it, isn't it? Because we're used to saying, oh, I'm an employer, I'll pay 50% of the premium. Many employers mandated that you paid at least 25%, right? I think that was Wellmark's threshold. Some carriers were 50%. And some employers paid 75 or 100% of the premium. Okay, remember now, we won't be talking like that. You can still do the math conversion and end up with what they're contributing from a percentage standpoint, but what we need to talk to them about, so this is another great talking point, besides the 90-day new hire waiting period, can't exceed 90 days from date of hire. This is the other interesting point to talk to them about because they have to change how they think about this. If today they pay 50%, no, the new way to think about it is I cannot mandate or require that my employee pay any more than 9.5% of their income in health insurance revenue, or health insurance premiums rather. So what number do they look at? I get that question a lot. 9.5% of your reported income to the government, your W-2 income. So it's that box on your W-2 form that's your wages and tips and whatever. So a lot of people say, well, does that include bonus? Does that include commissions? It includes, it's all that reportable income prior to all the adjustments. So it's not your adjusted gross income. It's your W-2 reported income. So here's what I've been telling employer groups. Sit down, and we'll do this with you, or you sit down with them and say, let's sit down. Who is your lowest paid full-time employee? Write that down. What's 9.5% of their income? Write that down. Divide it by 12. That's the monthly amount that employee can pay, can contribute, and no more, or your plan will not be considered affordable. And this is a big deal, and we'll come back to it in a little bit, okay? So that you got those two down. Also know that every employer offering coverage, guess what? They get to report it to the government. Why? Think about this. If somebody is getting health insurance and saying, or not getting health insurance and saying that they are in their tax return, but yet they were offered it by their employer, the government's going to know this now. So the employer has to communicate this. By the way, even the health insurance carriers are going to be reporting to the government who's enrolled in their health plans. So that's going to be their check and balance when the tax returns are being done to say if somebody's got health insurance or didn't get health insurance. Do we assess a penalty or don't we? So interesting reporting requirements. And then there's the pay or play. And this, I'm going to tell you guys right now, based on the business that you do with KHI, and some people only write a carrier or two through us. They don't write their major group carriers through us. But if you do, you will have access to this pay or play tool that we've purchased on your behalf so that we'll be able to really do some incredible modeling. We have your employer group person fill out a little survey to determine what this is going to be so that they can budget. It includes the taxes, and we haven't gotten to that yet, but we'll talk about taxes before the end here. So this pay or play calculation is available to you. Let your account manager know, or let me know. Let Tricia or Erica or Nakia know that you would like to talk about this pay or play. You've got a group case with us that you want to help the employer through. But incredible. And here's the other thing, guys. Some employees are saying, well, why don't I just pay my people a little bit more and say, go get your insurance in the exchange? Absolutely, they could do that. Absolutely, they could. And especially if they're under 50. They could even do it over 50. But there will be penalties assessed. And I'll talk on that in just a little bit as well. So just know that this pay or play, that vernacular is being used out there. Should I offer benefits or should I pay the tax? Should I play with health reform or should I pay the tax? And remember, if somebody pays their people more and says, go get your own insurance, remember now, they're getting no tax advantages, right, from paying their people more. In fact, they're paying more in payroll taxes. Now, yes, it's a business expense, but they're paying more in payroll taxes, of FICA, the Medicare, as well as workers' comp, as well as 401k contributions are all evaluated off of their pay rate. So think about that, and then they lose the deduction. If they are offering benefits today, they lose that deduction in their taxes as well. So there's great tax. They want to talk to their CPA about their tax situation, whether or not they should continue to offer benefits or not, regardless of whether they're over or under 50. So I've had people tell me, well, this really only impacts small employers over 50, right? Oh, the other guys don't really need to worry about it. Wrong. The little guys do need to. That's us. That's me. That's KHI. That's many of you that employ people. It's us, and we do need to care about this. Okay? All right, so let's go through a quick calculation on calculating those full-time employees that are called full-time equivalents only for the purpose of the calculation of, do you have 50 or more? Do you have to offer it or not? And if you're more, then you have to offer or get the penalty. Now remember, this full-time equivalents, they're calling full-time equivalents, are treated as full-time employees for the purposes only, as I said, of determining if they're 50 or more people. So the way you do it is you take the aggregate number of hours for all those under, how many hours? 30 hours. 30 is considered full-time. Know that too. That's another little tidbit that you can make sure your employers know. Did you realize that anybody working 30 or more hours is considered full-time? And if you are going to offer benefits, you must offer them to all people 30 hours or more. So let's take all those that are under 30 hours and add all those up and divide them by 120 on a monthly basis. So here, let's go to the next slide because I've got an example here. So ABC Inc. employs 55 employees. 35 of those work 30 hours a week or more. 20 of those only work 20 hours. Now, this is a really clean situation. Most groups aren't this neat and tidy. I had an employer say to me, Lynn, I've got some that work 35 and then they'll work 25 a week, and then they might be up to 38, but then they're down to 15. So it's all over the board, and I said, track it. You've got to track it and then look back on a monthly basis and what was their average. If they average more than 30 or more hours a week, you must treat them as full-time and you must offer them coverage if you're offering coverage. So see, this does impact anybody over or under because the way you calculate it. So now I take those part-timers, these 20, and we'll just, again, using round numbers, 20 hours a week. That's 1,600 hours in a month, divide it by 120, comes out to 13.3 full-time equivalents. We round down. The government says, I don't care if it's 48.9, 48.99. If it's 48.99, you round down. In this case, 48.3 full-time equivalent employees, they do not have to offer coverage. Now, I go back up, though, to their 35 employees. I must offer coverage to those 35 if I'm going to offer coverage. And I don't have to, but if I am, I have to offer it to all 35. I will be offering essential benefits. I will be offering a bronze, a silver, a gold plan, whether I'm in or outside the exchange. It doesn't matter. Okay? So in this case, this employer did not have to offer insurance coverage. Now, I'm kind of getting to the end here. We've got about 5 minutes, 6 minutes left, and I want to leave a little bit of time open for questions. So the shared responsibility continues in these penalties, and this is serious, guys, and that's where if somebody ends up being right at 50, or get this, let's say you're talking to them, you help them with the math, just do some quick math, and they find out they're at 45 employees. Your very next question is, do you plan on growing next year? Because how horrible it would be that all of a sudden somebody then grows to be more than 50, nobody's back in touch with them, they're not offering benefits, they sent everybody to the exchange, and now they should, and they're going to get socked with a penalty to the tune of $2,000 per full-time employee minus the first 30. So in this case, if somebody has 50 employees, 55 employees now, minus the first 30, so they're going to get taxed. Let's say they're left with 20 employees times 2,000, that's 40 grand in a penalty, and that's not tax deductible. So this is serious stuff for employers, and that's why it's frustrating because we're trying to grow our economy and we're hearing about employers laying people off so they can get below 50 so they don't have to offer coverage, and if they do, they're not penalized if they don't, or they're not penalized if they don't offer a quality or affordable plan. Because here's my next bullet. If I offer benefits, if I'm an employer and I offer benefits, but my benefits are either of poor quality or they're too expensive, right? It doesn't meet those two things we just talked about. I'm going to get dinged as an employer if I'm over 50. Remember, this is over 50, and I have to offer coverage. If one of my employees goes to the exchange because my plan either isn't affordable or isn't quality, if even one of my people goes into the exchange, they can get a subsidy now, then I'm penalized. So see, the government's driving employers to offer good coverage so that their people stay with them and don't go into the exchange. Why? Or into this new marketplace. Why? Because then the government has to subsidize with subsidies, and that's all on the taxpayer. That's the federal government. That's our taxes at work, right? So they're trying to incent employers that are 50 and over to keep their group plans. Okay, so there's tax implications, of course, and revenue provisions. So there will be refundable tax credits for all Americans that buy health insurance. So that's a good thing for both groups and individuals. So there's the small business tax credit and an individual tax credit. You'll see that on your taxes. Did you buy insurance? Yes. Who'd you buy it from? Great. And everything will check and balance. You'll get a credit on your taxes for purchasing health insurance. Now, having said that, the last four things on this slide and on the next slide are all revenue-generating taxes or fees to help pay for Obamacare. So I'll leave those there. I'm going to go through these. If you want this presentation, just shoot me an email and I'll send this to you. And you can use this and you can refer to this. I'm going to go to the next page, though. These are additional taxes. And we spent a whole session, part of an update session, talking about the fees. And so I won't spend any more time today because we're running out of time. But the annual fees, I've got documents I can send you, and or I will refer to those again and record a conversation on these conference calls so that you can go back in and listen to these. But there are fees that employer groups will also have to pay if they offer coverage. Again, all of this is to help generate revenue for paying for Obamacare. We also know there's another section, in a couple sections in the law that actually were repealed, and that was the 1099 payments to vendors over $600. That got repealed, and then this class, which was the Community Living Assistance Services and Support, that's really your long-term care. And that got nixed, which we were glad about that. And that really caused conversation, though, for us to have with our clients about long-term care. So it was interesting that they had it in there for a while, and that's gone. The last two sections of the law have to do with delivering quality of care. Now, this really has to do with the provider community, so I won't spend a lot of time here, but just know this, that they are gearing up to be able to play in this new space of accountability. They're creating these accountable care organizations and have programs where the hospitals will have more skin in the game if somebody gets readmitted for something that the hospital aired. Either they sent them home too soon or they left the gauze sewn up inside of them, right, that caused them to come back into the hospital for the reason that they were there in the first place. So there's some neat things also in the law. It talks about, so we want to make sure that physicians continue to go into this. The law has some forgivable loan issues in there for physicians that will go into practices rather, especially some of the rural markets, and forgive some of their loans. So there's some neat things they're doing to try to make sure we've got enough doctors in the marketplace, we're delivering quality of care. But again, the physician community is really wrapped around this. And then last but not least, they're talking about how else can we improve the health of all Americans, and how can we care about that? Because we just got done saying everything is guaranteed issue. So where's the incentive for somebody to be healthy and get a lower rate? It's not there anymore. So what can we do? Well, at least it's a start here with small businesses. They're going to offer a small businesses a tax credit for offering wellness programs. So this is another great way for you and I to get, for me to help you get in front of those small businesses and help them put together programs. We are now in conversation with a company that's going to help us help you offer wellness programs to your folks. And there's it's kind of neat because it's a distribution system that would allow an agent to be compensated then on helping to market a wellness program to your small group clients, and yet you're not the one delivering it. It's done by another company who's delivering this program to your small business client. So helps to keep your arms around your client. Good stuff here, and KHI is actually, we're implementing our own right now, and I've got some great stories to share with you on that. More webinars to come on wellness programs and how you can use this as a way to get into your clients. So I wrap usually with our customers, and we're right at 10 o'clock, and I know this was really fast. These sessions, by the way, I usually block an hour and a half, and actually I'll tell an agent, block 2 hours. Give me a 9 to 11 or a 1 to 3 time slot or something like that, and then we'll have conversation, Q&A, and then there's just leaves a little bit of window open for, so usually an hour and a half is what you want to block, but 2 hours, 1.5 to 2 hours. So Will we solve the problem? I always end on this, and I said, I think we will get more Americans insured. I believe that we will. We've got the vehicle to do it. If the agents will step, we're ready to step up, but I don't know that we're going to be able to tackle the rising cost of health care. And my opinion is we've got two components to that, and one is continue to get people engaged. I think high deductible health plans, that's going to be key. The flex spending accounts, some of those kinds of things we need to continue to improve on, as well as wellness, and everybody taking responsibility for their own health and their own wellness so we can eliminate some of the chronic conditions that are caused by our behaviors. Okay, so with that, that's the end of the presentation, and I'm going to unmute, see if I can unmute the phones here, and let me see if I can get to it and see if you guys have any questions. Okay. And I'm having a little trouble. Let me see if I can get to the audio here. Okay, I'm having a little trouble. I think some of you guys are probably dropping off now. I'm having a little trouble trying to get you guys so you can ask some questions. Let's do this, you guys, and I apologize, and we are right at 10 o'clock. We've got another webinar at 10:30, and I'll get this figured out on how I can make sure I get this unmuted next time for our next call. Send me if you've got any other questions, you want to email me, go ahead, and I'll look forward to hearing from you guys, okay? So have a great day. Thanks so much for your attention today. Sorry about the problem here, and we'll talk with you soon. Take care. Bye-bye.